Good morning and welcome to the West Yorkshire Joint Health Overview and Scrutiny Committee meeting. The first item on the agenda is membership of the committee and to receive apologies for absence. I know we have Councillor Lee apologies. Do we have any other apologies for absence?
Yes, we've also got apologies from Councillor Lay.
Thank you. Okay. Minutes of previous meeting then. The minutes of the previous meeting have been circulated. Um, Do we take them as a true record for those that were there? If members of the committee could indicate that they agree those minutes, please. Yes, thank you very much. Are there any comments on the minutes? Councillor Hutchinson.
It's on page 4 of the pack. There was various items of information requested to be sent to the committee after the meeting, and I don't believe those have been sent. And then the other thing was on page 5, where we'd been looking at the West Yorkshire Association of Acute Trusts, and we decided that the committee will consider how best to scrutinise Wyatt's work as its influence increases, and I don't believe we've had those discussions.
No, we will make sure we have those discussions next time, and we will chase the items. Okay? I know officers are already on with that. Are there any other comments on this, on the minutes, or anything anybody wishes to raise at this point in the meeting? Councillor Rhodes? No? Okay. Right then. So, declarations of interest. Does any member of the committee have any declaration of interest to declare? Councillor Hutchinson?
I'm not sure whether it'll be relevant to the discussions, but I am a member of the British Medical Association and a fellow of the Royal College of Ophthalmologists. And I'm on the executive committees of Doctors for the NHS and Keep Our NHS Public.
Okay, thank you. Anybody else declarations of interest? If anything comes up during the meeting, can you please ensure that you declare that interest and that you complete the relevant forms, please? Deputations and petitions, then. We've no petitions or deputations that have been notified to the committee this morning. So, Councillor Rhodes?
Thank you, Chair. Can I just bring to the attention of the committee this morning that I would be very interested in proposing or suggesting that we as a joint committee would look into a review of our maternity services across the patch. Bearing in mind that as 5 authorities here, we both come under different trusts in terms of that provision. And I think it would be useful to have a word with the officers to set up such a scope as soon as possible. And at the same time, it's got to be noted that within the scope and the remit of the committee, we understand that any movement across boundaries is the right of the mum-to-be to choose where the baby is born. But outside of that scope, obviously, would be including other needs such as antenatal care, etc. So if the committee would support that, Chair, through you, can I ask that that's part of an agenda as soon as possible?
Yes, Councillor Rhodes, does the other committee in agreement with that? If you just indicate yes, please. Yeah. Okay, thank you. Yes, we will certainly bring that forward, Councillor Rhodes, and officers can work on the scope of that discussion. Okay.
Thank you, Chair.
Thank you. Thank you. So we move then to the West Yorkshire Integrated Neighbourhood Health Update. Hayden, I believe this is yourself that's going to present this report.
Yes, Chair, that's right.
If you could have you got your camera on at this moment in time? Ah, right, okay,
have.
there you are. Okay, thank you.
No
Over
problem.
to you.
Thanks very much, Chair, and hello everybody. I'm Hayden. I work for NHS West Yorkshire Integrated Care Board in our strategy and transformation function. And I have worked with some of you previously on other matters, but I'm now working on a range of things, including integrated neighbourhood health, and that's what I'm here to talk to you about today. So I've provided a paper which I hope you've found helpful and comprehensive, and what that paper effectively sets out is some of the context, both locally and in terms of national policy. It sets out how across West Yorkshire we are beginning to deliver on our neighbourhood health priorities and provide some next steps as well. There's also an appendix to the paper which sets out some sort of fairly high level and indicative areas of focus on neighbourhood health within each of our 5 places across West Yorkshire. That's in Leeds, Bradford, Calderdale, Kirklees and Wakefield. So I'll not speak to the totality of that paper, but I will draw out some key points for you linked to each of those sections that I've just outlined. So on context, then I guess there's a couple of points I'd like to raise. One is that I think we probably all acknowledge this, that neighbourhood health as a sort of concept and an area of focus is not a sort of unique or particularly new thing, and I think colleagues will recognise that it fits within that broader sort of left shift agenda, the sort of providing more care in communities agenda more broadly. And I think what we've seen nationally is a number of programmes and areas of work that have focused on delivering exactly this. And I think that's coming to a head now in the form of the focus on neighbourhood health. I think that's supported by and complements the local ways of working we've developed in West Yorkshire over many, many years. Clearly, though, neighbourhood health as a sort of terminology is a big government priority at the moment. And I think that's set out really clearly, specifically in the hospital to community shift that the Secretary of State has articulated, but it's also supported by the treatment to prevention shift and the analogue to digital shift as well. So all 3 of those big shifts are incredibly important and articulated in the relatively recently published 10-year health plan. What's also set out on context is that we've not only got things like the 10-year health plan, but earlier this year in January we received a publication on neighbourhood health guidance, and that sets out 6 core components of neighbourhood health, which are listed in, I believe, section 2.6 of the paper. The final thing I'd note by way of context is that, and I'm sure it won't be lost on any of you, that the health and care landscape is changing at pace and quite dramatically. And I think that's incredibly important when we think about what we are delivering on neighbourhood health. You know, the ICB is refocusing in line with national publications to become a strategic commissioner and will be required to publish a 5-year strategic commissioning plan that's focused on our strategic commissioning intentions and is focused on delivering outcomes for patients over that 5 years. Providers will continue to focus on delivering sort of operational provider plans and on neighbourhood health specifically, as I'm sure you will all be aware. The requirement will be that there are neighbourhood health plans that are developed which are held by the health and wellbeing boards in each of the 5 places, and those plans will be expected to be both strategic and operational in nature. I think we are waiting further guidance on the development of those plans, but that feels particularly pertinent to today's discussion. If I just draw out some highlights on progress, I think what you would see looking at that paper is that the vast majority of progress on neighbourhood health sits within each of the 5 places in West Yorkshire, and that feels right, given that neighbourhood health is inherently an incredibly local thing and needs to be delivered in communities working with the very people that receive those services. I think that will also be helpful for the health and wellbeing boards as they are developing those neighbourhood health plans that I've just set out. And I am aware that in each of our 5 places, ICB teams and colleagues will be working with local health and wellbeing boards to support the development of those plans. Other things you'd see if you look in the progress section of the paper is that 3 of our places, so this is in Bradford, Wakefield and Leeds, have become National Neighbourhood Health Improvement Programme sites. So the NNHIP is a national accelerator programme for neighbourhood health. It's working with, I believe, 43 sites across the country. And those 3 places I've set out in West Yorkshire are working really closely with national teams to get enhanced support, but are working locally to rapidly roll out neighbourhood health services for priority population groups that we think would both benefit from receiving those services, but importantly, we also know that they will help us to reduce unplanned hospital demand as well. In addition to that, and clearly set out that it's only 3 of those places that are 3 of the places in West Yorkshire that are part of that programme. All 5 of our places are working on neighbourhood health and have got priority areas of focus. So you will see reference to things like priority cohorts in there, and they are again cohorts whereby we've looked at the data that we hold as a health system, tried to identify whereby there are sort of groups of patients that are accounting for a disproportionate share of unplanned hospital demand, and we are focusing on rolling out neighbourhood services that support them in their communities and prevent them from needing hospital care. So that process is set out, and then the other things that you would spot in there is that we've invested £4.1 million of non-recurrent service development funding this year to support the transition towards neighbourhood health, and we have got a range of sort of projects that are included in that, ranging from things like digital to the sort of cultural and organisational development work we need to ensure that professionals can work together. And we're also involved in a bunch of local, regional and national work that are focusing less on the specific delivery of neighbourhood health services and more on the sort of strategic enablement of those, like the financial flows and the contracts we need to see in place to really embed the shift towards neighbourhood health care. In terms of the next steps, there are a number of areas set out, but I think what they broadly fall into is 2 overarching categories. I think there's one aspect whereby we're talking about continuity, so we should continue building on the progress we've made today. We should continue to roll out services in the way that we're describing each of the places, and I've just articulated at a high level here to you all. And we should build on that as we do that, and as I've said, we should ensure and work with health and wellbeing boards to build that into development of neighbourhood health plans. I think the second sort of camp of next steps is around how we adapt to the new and evolving health and care architecture. So we need to ensure that as an ICB, so we're developing our 5-year strategic commissioning plan, we're doing so with the focus on neighbourhood health, but in line with the remit that's being set for that plan, which is to be outcomes focused, population health need informed, and to set strategic commissioning intentions. And equally, we need to see that the delivery of neighbourhood health is there's a sort of strong read through in both provider plans and clearly in the neighbourhood health plans that I've outlined, that health and wellbeing boards will be accountable for developing and delivering. And then I guess there's a bit whereby we need to make that all work together. So there needs to be a strong read through from intentions right through to delivery and those neighbourhood health plans. But that's a sort of system architecture style of question, I think. So I will perhaps pause there, Chair, and hand back to yourself, and happy to take questions.
Okay, thank you. Just before I open it up to questions, can you just give us timescales when all this needs to be in place, please?
Yeah, so some of it, so if I started with the neighbourhood health guidance that we're expecting to be published, so we're not entirely clear when that guidance will be published, and we are expecting that will provide a timescale that health and wellbeing boards will be required to develop and sign off those plans. So that's currently unclear. We know from an ICB perspective that the 5-year plan that I've set out to you will need to be submitted to NHS England by February 2026, and we'll be expected to review that on an annual basis. I think the timescale of delivery more broadly is very iterative in terms of the neighbourhood health rollout, but I think we would expect to see some more detail on that through the guidance that I've referred to. I guess the other thing that we would see is that the 10-year plan, clearly by name, is a 10-year plan. So I think there's an acknowledgement that it's a sort of 10-year period of change, but clearly there's a 5-year sort of interim ICB plan. But there's not anything perhaps more precise than that at this point, Chair.
Okay, thank you. Councillor Rhodes.
Thank you, Chair. Good morning, Hayden. 1 or 2 things in terms of the report here. First of all, do forgive me. You mentioned care in the community. Could we please make sure that name is not expressed in terms of the plan that you've got in future in front of you? Because care in the community came about through mental illness changes many, many years ago. And I think we've got to make sure that we're not, in anybody else's mind, crossing over into some other plans. Forgive me, Hayden, I've been around a long time and worked on that one as well. So I'm glad you dropped that expression of what it was going to be and went on to the neighbourhood plan. I think the report itself here is quite a good report. It's a short report, but it actually does cover all the issues that we hoped it would. Now, you've got the neighbourhood health guidance, and then lower down you've got the guidance later complemented by the 10-year health plan, and recently the medium-term planning framework. Okay, and then of course we've got the changes that are going to take place. How are both of these going to work together? Because plans are all over the place, and we want one concise plan, but I do appreciate that it's going to be February time, I believe you mentioned, before you've got some further information. And secondly, on 2.15 under the local context, it's focused on rolling out the models for high priority cohorts, etc. And I'm looking across here, and I think obviously the cohorts are just examples, but within this cohort, forgive me, it's probably there already, but one of the bigger issues across the patch for all councils and all communities of late is the prevention agenda, and mainly as well to deal with the increase that there has been in mental illness and suicide, etc. Now, those are real issues in the community. So forgive me if it's part of the background detail, but can you just assure us that that is not going to be a forgotten agenda in terms of stress out there in the community?
Thank you, Councillor Rhodes. Chair, would you like me to respond to those questions now? Sure. So thank you, Councillor Rhodes. I think the point you make around care in the community is a helpful one, and I think, as ever, we just need to be really careful with language, because, as you say, a lot of these things, whether it's words or acronyms, have been thrown around before. So let's be clear on what we're talking about. I agree with you on that point. I think the second point you made was around how we're going to. There's a lot of plans that are emerging, a lot of frameworks that are emerging. How are we going to ensure that they are knitted together and make sense as a whole rather than individual plans? And I think that's probably the one of the most important questions we've got to answer. I'm confident in the process we've set out to develop our 5-year strategic commissioning plan is one that tries to align all of those requirements. So we work really closely in our team with our planning and performance team, who work really closely with our acute community and mental health providers, who work really closely with their places who are working on the development of neighbourhood plans. So I think there is that triangulation and read through between each of those requirements. I think that's also something we'll need to embed in the way that we work going forward. But I'm confident the process we've designed is the right one, and we did agree that process as a system through one of our many different governance forums. And then your question about high priority cohorts. So what you'll see, you're right, there's a sort of line in the main body of the paper itself that provides some examples, and that's because there's a degree of commonality across all of our places on the sort of high priority cohorts. If you look in the appendix, you will then see the specific cohorts for each of the 5 places as well. I think your question about prevention is incredibly important, and when we were developing our neighbourhood health work this year, we framed our focus on 2 North Star metrics. The first of those North Star metrics was around reducing preventable unplanned demand for hospital services. The second was around increasing early identification and prevention. So when we tasked all places with going away and identifying their cohorts, we were asking them to identify cohorts where we would be able to make an impact on those 2 North Star metrics. I think if that's perhaps not coming out strongly enough, that it would need to be a conversation in each of those places to understand specifically what the prevention focus was on which cohorts, and if in the specific example you've raised, whether suicide prevention, for example, is in the scope of that.
Okay, thank you, Chair.
Thank you. Councillor Hutchinson.
Thank you, Chair. Looking at the 6 core components of neighbourhood health, that a lot of these require, the left shift for more care in the community rather than hospital requires a workforce that is skilled and appropriately trained to deal with more complex patients in their own homes, and has the self-confidence to actually do that when you don't have direct access to other support staff, which you have in a hospital. And that is a core part of the training of district nurses. I'm not talking about community nurses, I'm talking about people who go through the district nursing qualification. And the Nuffield Trust produced a report in October pointing out that there's been a 43% reduction in the number of district nurses over the last 15 years, which is a substantial reduction, particularly when you consider the greater number of elderly people that there are in the population over that time. So if we're wanting people to be able to assess what care for an individual patient, what care is possible to be given safely within their own home, if we're wanting to have more end-of-life and palliative care taking place in people's chosen place that they wish to end their days, and if we want the urgent community response teams to be working as well as they should, we need to have an appropriate district nursing workforce. And as a country, we do not have that. And it's been very difficult to know what the situation is in West Yorkshire. So a lot of the problem is that there's been a reduction in the number of tutors and placements available to actually train up the next generation of district nurses across practices. What are we doing, if anything, at West Yorkshire level to actually make sure that we have a workforce that will allow us to deliver safely that out of hospital care? And I would make a similar point regarding health visitors too.
Thanks, Councillor Hutchinson, and I think a point well made. I think a point that we'd certainly acknowledge that a lot of this does require a shift, as you've described, in the confidence, the competence of our workforce, and also a kind of change in the way that our workforce works. So I think we probably currently have a model whereby our workforce work in organisations rather than across these sort of broader neighbourhood footprints. And one of the things that we've absolutely acknowledged from the outset is that this is about how we use the resources and the capacity that we do have differently. So whether you're a nurse perhaps working in an acute hospital or in a community service, we need to make that work. I think so I can pick up some of the specific questions there with perhaps say our community health provider collaborative and work with that. I'm not aware of specific work ongoing. I think it looks like I can see James's hand coming in, who might want to answer that question more materially as well. So hand over to you, James.
Hey, James.
Yeah, thanks, Chair, and thanks, Hayden. Really spot on question, Councillor Hutchinson. So my name is James Thomas. I'm the Medical Director at the ICB. And you're absolutely right, as Hayden said, workforce is going to be key to any of the delivery, along with digital, but workforce, as you've highlighted there. I suppose I just wanted to come in terms of some specific things that we've been doing across West Yorkshire to try and increase the exposure and therefore hopefully the kind of willingness to work more in the community. We've been working with our workforce leads across West Yorkshire and had a very successful approach in terms of kind of having what we call student-led clinics, which have been sitting within our community and within general practice. We've got some good examples across West Yorkshire where we have enabled student nurses and other allied health professionals to kind of in their student days work out within the community, working with our practice nurses, working within the community setting. Recognise actually they got a broader training there, but also exposure to working out in the community, which I think fundamentally is one of the issues, is that the exposure to working in the community, seeing the opportunities, is not always given to our students to see that and to have that exposure to kind of think, actually, I want to go and work out in the communities there. So I think the thing that we've been doing this with student-led clinics has enabled greater awareness of that. What we're hoping to see is obviously that translating into people wanting to work in the communities. But you're right to highlight that as an issue in terms of workforce. And it's something that I think very much is not only are we not just around district nurses, not around just health visitors, but I think other allied health professionals, how do we make sure that we give them exposure during their training so that they can see this as being both an opportunity, but also have the skill sets to work within the community, which is different as you've explained. Thank you, Chair, and thank you, Councillor.
Thank you. Councillor Hutchinson, did you want to come back, or you okay?
I'm really sorry, my connection dropped out
It's okay.
through most of Dr. Thomas's response. So I'll need to look at the record. I'll need to look at the recording.
Okay. All right. Thank you.
Could on a separate question, could I also ask about the neighbourhood teams are being set up to be largely match the geography of the primary care networks. And I was wondering how those would actually interact, if at all, where the primary care network, how they're going to work together seamlessly to provide that model of community care in the communities.
So Hayden, is that yourself?
Yeah, I can take that question, Chair. Thank you. And you're right, Councillor Hutchinson. I think almost everywhere in West Yorkshire we're building the neighbourhood teams on the geographies of the primary care networks. As you say, the reason that I think we're doing that is because we recognise it's a geography that people acknowledge, they recognise, they understand, and there's a strength in the assets that have been built there. I think on the specific point of how they are interacting would be a question for each of those PCNs and neighbourhood teams. But I think your point's absolutely right that they will need to work together. The PCNs will continue throughout next year to have the contracts that they currently hold, for example, and those services will need to interplay. And I think the broader point that you're alluding to really is that there are a range of services that currently operate that would come under the neighbourhood health umbrella. And we need to ensure that they work together rather than as individual siloed services. And I'm confident that work is happening in each of those areas for those priority cohorts.
Okay. Thank you.
Yeah, I was just a little bit concerned about that answer, Hayden, but you qualified at the end. Surely you would need to understand how those teams are working together in all the areas in order to ensure that this is being delivered across the West Yorkshire. Councillor Griffiths.
Can you hear me now? Yeah. My first question, I think, has been partially answered. I was going to ask how big a neighbourhood was, because it's not clear in there. But I take it to understand that it's loosely going to be on the geography of primary care networks. Although those are quite variable in size, I think, unless it's changed, and sometimes they're not geographically contiguous, so there may be issues there. And the comment I was going to make really is that it's about these neighbourhood multidisciplinary teams that are being mooted. And just to say that when I started out in general practice 40 years ago, we had a thing called a primary care team where district nurses, health visitors, general practitioners, midwives all work together, often co-located, dealing with multiple patient cohorts within a usually fairly clear geographic locality. And it's just nice that people come round to the good ideas back again.
Thank you, Councillor Griffiths. Chair, would you like me to respond on the size of neighbourhood health, neighbourhood team point?
Please.
So you're right, Councillor Griffiths. They are largely based on the primary care network geographies. I think what that does mean is the actual sort of population size of each of them does vary. I think what we've gone with is that if it makes sense to those local areas, then that's the right basis on which to proceed. The other point you made about them being geographically contiguous is a good one as well, because not all the primary care networks are, as you say. I do know of certainly one where there was a challenge in that, and that challenge has been overcame. And I think the decision was to go from perhaps what was 6 or 7 PCM footprints to what is instead 5 or 6 neighbourhood footprints. And that was a resolution of that point that you made around being geographically contiguous. So I'm confident again that where we're encountering those challenges, we're overcoming them.
And I just that can you just make it clear? It's probably me that's not getting it this morning. So I had read the paper and said that it would be on the primary care network footprint. Are you talking about a neighbourhood team per primary care network? Or are you talking about a neighbourhood team across several primary care networks? Because that answer seemed to allude to the latter.
Okay. Sorry if I'm unclear on that point. So I think there's two things here. So, well, maybe three. So we've got the primary care networks, which we all understand. The neighbourhood sort of health footprints have been shaped on the basis of that primary care network geography. And then neighbourhood teams will come together within those geographies, so the same as primary care networks, to meet the needs of whatever that population is. I think the part where it becomes quite complicated, Chair, is that exactly what that neighbourhood team needs to look like, who needs to be a part of it, fundamentally depends on the patients within that cohort, which is where it becomes slightly more complex. So I think at the moment it's very much within the geographies that we're alluding to, sort of PCN geographies. I think in future, if you looked at national policy, for example, there is talk around things like single neighbourhood providers and multi-neighbourhood providers. So that's when it starts to become a little bit less clear, but we're still working through the clarity on that point.
Okay, thank you. Councillor Jamil?
Thank you, Chair, and thank you for the paper. I just wanted to focus a little bit on the digital stuff, and I know that there's a big focus on analog to digital as part of the plans. And I see in the paper that, this talks about focusing more on digital solutions and improving access, particularly around the primary care, which I think is a good thing. So that, because obviously we know that there are issues at the moment in terms of access to primary care in a lot of areas, and sort of, opening up that and allowing more digital solutions around that surely is a good thing. But what I want to focus on and what my concern would be is that we're not excluding anybody from that focus, and we ensure that everybody who wants to access digital, and if we are going towards that more and more as the future goes, that we don't leave people behind. Obviously, more elderly people who may not be very digital savvy or don't want to sort of go onto that digital platform, people with certain conditions, people whose English is not the first language. So what are your plans to ensure that we don't leave people behind when that focus and that continued focus on digitalisation continues as part of these plans?
Thank you, Councillor Jamil, and again, another really good point, well made. And I think we do certainly recognise as an organisation and within our work on neighbourhood health that digital exclusion and digital poverty and various other sort of areas around digital are incredibly important. And I think what the sort of position we're working towards is digital being an option for people, and it should hopefully make things more efficient. You can access care more quickly, but I think importantly what that should do, and we shouldn't see these two things as separate, is, if you sort of simplify it, if you're making an option for you to book your GP appointment online, then it should free up the phone lines for those folks that are perhaps less confident using digital option. I think that is very much the approach we're taking. So we have, I'd mentioned the £4.1 million of service development funding. A proportion of that has been allocated to something that is referred to as modern general practice access. And the focus of that is on ensuring we've got the digital and telephony systems in place so that they work. So I think it's both and, rather than just going sort of full digital. It's making sure it's an option and acknowledging, as you rightly say, that there are groups of patients, whether it's the elderly, whether it's people experiencing more poverty, that just may not have the credit on their phone, the access to a data plan, whatever that might be. So we need to ensure that both are in place, and that very much is the basis on which plans are being developed. I think if it was to be more specific in that, again, it would need to be a question of each of those neighbourhoods on how they are progressing those plans there.
Are there any further questions on this item then? No? Okay, thank you very much for that. So we will move on then. Oh, before we do, just let me do the summary. So we talked about digital not excluding, ensuring that people are not excluded. The PCN networks, how they're going to interact and ensuring they're working together. And ensuring that the plans, different plans, all work together and don't work in opposition to one another, and how you have robust delivery of this across the whole of West Yorkshire. And skilled workforce, we were queried about ensuring there is a skilled workforce across the piece, and the local context, about having conversations at the place levels about the local items that have been put forward to concentrate on. I think what we'd want to know going forward is how the delivery of this is moving forward and how effective it is being to ensure that services are within people's neighbourhoods that are being accessed. Okay, and that demand on what you've said as your priorities is actually being fully met. Okay, all right. Thank you ever so much for that. So now we move on to autism and ADHD assessments. Dr. Thomas, is this yourself that's going to lead, or is it Keir that's leading on this one?
It can be both of us, if that's okay.
Yes, thank
Chair?
you.
Right, so thank you very much, everyone. My name is James Thomas. I'm, as I said, Medical Director at West Yorkshire Integrated Care Board, and I'm also a GP. It's a really pleasure to be here today. So we're here today to kind of give you a current position regarding the autism and ADHD assessments and outline the kind of strategic plans and to address the challenges that we all know about and hear with the assessments and the treatment there. So Keir, I'm joined by my colleague Keir Shanaka, who's going to kind of go into a little bit more detail with the paper there. But he will draw out kind of key areas around the kind of background to this, the timelines, some of the key issues, and then the next steps that we're proposing. Before I go on, I just also want to just apologise because I know that you received my letter about a month or so ago there, and I think it came across really cold because I don't think there was an engagement we had hoped to have had. So I want to apologise beforehand in terms of that, but I hopefully can make up with the opportunity today in terms of giving you an update of what's happened, but take on board. And I think it has been noted that in terms of how we communicate some of this out with you through our places as well there. So I just wanted to make that point as well. But I want to start off by saying that really with our approach, which we've kind of looked at particularly over the last couple of years, but I know it's been longer than that, but our approach over the last 18 months has been based on ensuring that what we want to do is create a unified, equitable and a needs-led neurodevelopmental pathway across West Yorkshire, so that we kind of have a unified West Yorkshire neurodiversity commissioning policy, and we have community neurodiversity-based hubs in our places. And if we have this approach, we will help make sure that we ensure a consistent pathway principles and thresholds for our individuals across West Yorkshire for assessment and for diagnosis, to kind of minimise the inequity and to minimise the inequity of access that we're currently seeing as well. We want to ensure that we've got a single point of access and referrals for assessment based on need and not on just the diagnosis. It needs to be, as I said, needs-based support, and making sure we've got needs-based support before a diagnosis as well. And we need to ensure that we've got accountability in those assessments, and we've got quality assurance of those assessments through our clear commissioning criteria there. If we manage this and we bring this together, these elements will enable us to ensure we've got a fair, a consistent and a sustainable neurodiversity system for all across West Yorkshire. And hopefully the paper goes into a bit more detail of what we've done and what we've been doing and some of the issues that we've come across and what we're going in terms of the next steps. And I'll ask Keir to kind of quickly summarise that, if that's okay.
Thanks, James. Hi, everyone. So my name's Kia. I'm Programme Director for Mental Health, Learning Disability and Autism, so work on behalf of our mental health trusts and the ICB. So yeah, as James says, I'll just give a bit of context to start, I guess, to kind of set the scene. So if we look at referrals for autism and ADHD assessment, they've more than doubled over the past 5 years, and this is reflective of the national picture. It's not just something within West Yorkshire, and as a result of that, when we look at our waiting times, they're often very variable. They stretch into months or years, and that reflects the national picture as well. When we look at clinical focus on this, so there's no standardized national approach, often in terms of diagnostic criteria, and we know how valuable the diagnosis is. So it's extremely valuable, not just from a health point of view, but it's also extremely valuable for people with autism or ADHD from a non-health point of view, particularly in terms of what support they might be able to access in terms of their wider social environment, or from an education point of view for children and young people as well. For ADHD in particular, we know that through the Right to Choose process, there are many independent providers who will offer to provide an ADHD diagnosis, but that doesn't always lead to that same provider providing the medication element. So what we are seeing is there are occasions where somebody may be diagnosed with ADHD, but then be re-referred back into the local system to try and pick up the medication elements, and that obviously generates a wait, and it generates another kind of step for those individuals to go through to be able to access their medication. And when we look at our autistic population, looking at their outcomes, when you compare the autistic population to the rest of the population, generally speaking, their lengths of stay, particularly from an inpatient mental health point of view, are a lot longer, and they experience poorer outcomes. So there is a real need to try and make sure that we are providing the right support and as seamless access as we can into services for people who have ADHD and our autistic population. And then when we look at some of the kind of the fundamentals and the building blocks we've got around neurodiversity, when even I compare it to the wider mental health world, which is comparably worse to the physical healthcare world, the data we've got on autism and ADHD, the completeness of data, the quality of data, the flow of data, the analytical capacity is not there up and down the country at the minute. And then when we look at costs, the Right to Choose option is essentially whereby people can go to their GP and be referred to any provider in the country to try and get a diagnosis. We know that the Right to Choose costs for us as a system have tripled over the past 3 years. And because the Right to Choose system allows people to choose providers up and down the country, that means that we can't necessarily assure the quality of those providers either. And what we want to do, as James alluded to, is try and make sure that there is a better quality assurance where we possibly can of the diagnosis that people are getting, and that, you know, from an ADHD point of view, they can then be followed up with the medication pathways. So at the outset of the work that James alluded to, we held a couple of large neurodiversity summits with people with experience, health professionals, local authority, voluntary and community sector representatives. And what that did, really helpfully, although slightly unhelpfully, I guess, at the same time, it surfaced the differences of opinion we've got on how to tackle these challenges and on which areas to prioritise. But through an awful lot of engagement work, we did settle on exactly those areas that James alluded to. So particularly around the single unified commissioning policy. So how do we get the consistent criteria and make sure that any of our providers meet those thresholds, and then the focus on those community neurodiversity hubs, particularly around the single point of access, and particularly around making sure that people's needs are met, regardless as to whether they have a diagnosis, are waiting for a diagnosis, or come at the end of that process and do not get a diagnosis but have still got needs that need to be met. So to date, some of the work that we've done has been around agreeing those West Yorkshire clinical quality standards. So how do we make sure that we have absolute clarity between our providers of care in West Yorkshire, between the NHS providers and the independent sector, about what clinical quality looks like, and that all of our providers in West Yorkshire have to meet those quality standards. And the good thing is that in some of the work that we've been doing jointly with colleagues in other ICBs in the northeast in Yorkshire, is that by osmosis trying to make sure that everybody starts using those clinical quality standards. So other ICBs are starting to look at those too. And what we hope that does is it increases the pool of providers who meet the quality standards and therefore reduces the pool that don't. We've developed the indicative activity plans, which is basically there to ensure that our providers that we are contracting with, or through the Right to Choose process, do the same number of assessments as they did last year, or that for our West Yorkshire providers that are accredited, they get up to kind of 10% and more activity, and that we utilise that capacity to focus on the longest waiters. But we do have to be honest that kind of what that might do is it might mean that people, while we try and equalise those waits, to make it more equitable, it might mean that some people wait longer than they were expecting to. And then from our providers' point of view, what they are trying to do is look at how they review waiting lists to monitor well-being, and that they are still able to escalate any urgent cases beyond their activity plans where they possibly need to, and that the information that our kind of patients and the public get is really clear, really accessible, and they understand what options there are available to them in terms of needs-based support and advocacy within their kind of local areas. And as James also alluded to, the next steps that we're trying to work on really intensively over the next few months is particularly around those clinical thresholds. So how do we get clear agreement about what a diagnosis should be and should deliver, and that we equalise those thresholds so that people in different bits of our patch across West Yorkshire aren't more likely or less likely to get a diagnosis depending on which provider they're seen by. As part of the commissioning process, to do that bit about standardising the waiting list so there's equity across the patch. And then beyond that, the longer term piece of work is trying to develop essentially the business case for that community neurodiversity hub model. So what do those hubs look like? We talked about integrated neighbourhood health earlier on. How does it interface with that bit of the world? How does it interface with our community mental health division as well? And how do those hubs bring in not just the specialist support element, but primary care, education, local authority, VCSE support, so that what we are doing is recognising that for our population who have ADHD and our autistic population, what they generally need is not something that health provides in isolation. It is absolutely about that wider social support, educational support, and recognising that it's based on what people themselves want and need, and rather than what's clinically or in isolation the NHS or the health services there is offering them. So yeah, I'll pause there if that's okay. Yeah, it's just a bit of a summary to what's in the paper.
Thank you. When I can get my mouse to go over the right icon. Thank you for that. Can I just clarify, because you really don't have a lot of timescales in this paper. I take it that you have restricted activity, but that all of the rest of the work in this paper is subject to business cases and timescales. So what are your timescales for all of this work?
Shall I come back on
Yes.
that?
Okay.
Go on, Jim.
Well, I was going to say, so I think in terms of some of the next steps, we talked about kind of developing the clinical thresholds. That's something we want to be doing. We're embarking on straight away at the moment. They're aiming to, I would be hoping that we'd have agreement with those thresholds by the end, by March of 26. What we're doing concurrently also is starting to look at what the neurodiversity hubs would then need to kind of develop there. And I would see that going into 26, 27, probably towards the end of 27 in terms of developing those neurodiversity hubs. So we're looking at towards the end of March 27 is that we want to start to see that we've got plans in place and of neurodiversity hubs to be able to start with and in between that time, we're starting to develop those clinical thresholds and utilise those clinical thresholds as well.
Okay, so your clinical thresholds, you're saying there are differences across West Yorkshire at this moment in time?
Yeah, there are.
There are differences. There are differences in how people present with autism. People have different characteristics for autism. So, how are you looking at those clinical thresholds? What level are you taking in order to ensure that your clinical thresholds then do not exclude people who would otherwise have had a diagnosis?
So our plan is we're bringing together the appropriate people, clinicians who have the knowledge there to kind of have that discussion to understand. And I accept that what you're saying in terms of, it's about not excluding people there. I think what we want to try and do, as I said, is get some using the right people, and making sure we've got a range of people as well. We're not just got, because we know we've got people with extreme views, with different views of those thresholds there. It's kind of how do we kind of understand those to help us with the thresholds. But at the same time, the other issue around this is also around the needs. What are their needs as well, and ensuring that we're developing services that can support the needs of those people, whether they've got a diagnosis or not, or whether they're waiting or not.
Okay, all right. Well, it's not all right, but
no, it's challenging,
and it is challenging,
yeah.
And Yes, I will reserve comment until the end. I will open it for questions then. Councillor Lawson.
Thank you, Councillor Spade. Is going back to something that Keir actually said regarding ADHD diagnosis, and it seemed to imply that there were providers commissioned that would only give a diagnosis. Then the person or parents and carers would then have to wait again to see somebody else to actually maybe get treatment. How long are people waiting anyway for an ADHD diagnosis? And then when they've got, say if they were with a provider who could only give the diagnosis, not the treatment, is how long are they then waiting for to see somebody that could give the treatment, or is that a case that they would then go and see their GP? Because to me it just seems is like waiting for X amount of weeks or months, and then to be told, yes, you've got this, but we can't treat it, seems to be a bit pointless. And obviously people are gonna worry about sort of, you know, how long they're gonna be waiting.
Shall I come in on that?
Yeah, Keir, yeah.
Yeah, I mean, just to be really honest, that situation that you articulate, that bit about it being completely pointless and being unfair on the individual is absolutely true. What we, just to be really, really clear, when we are talking about independent providers who then might not follow on with the medication, these are not the providers that we have accredited and that we commission in West Yorkshire. This is about the right to choose process. What the right to choose process is really good at is being able to say, actually, there may be long waits in one bit of the country, but over another bit of the country, there's a provider who is offering to provide the diagnosis, and they may well do it quicker. So you can potentially get your diagnosis quicker. But because we do not commission those providers, if they turn around and do the diagnosis and then do not provide the medication pathway, then we have no commissioning levers over that provider. So what it means is they might wait a number of months, shorter time frame to get their diagnosis of ADHD than maybe if they waited in West Yorkshire. But then they will not pick up the medication pathway and then would have to be re-referred to one of our local providers. So it doubles the wait essentially. Doubling might not be quite the right amount, but it essentially makes there's a doubling of the wait, because you have to then go back into the local system, because we've then got to pick up the medication.
If I can just come back on that, is patients or their parents' carers are obviously being able to access these providers, and I'm assuming it is sort of via sort of an NHS choose and book type system. Call me a bit old fashioned. I've been out of the NHS for a few years now, so somebody is commissioning them.
Yeah.
Who's going to come in on that?
Can I come?
James, yeah.
So you're right. There can only be a provider on the NHS if someone has approved them and commissioned them there. What we're not certain about is there's two things with that. One is in terms of the kind of quality side of things of that, and yes, one would expect there to be the same sort of quality across the nation, but but we don't always see that. The second thing I think is also about the medication is, and kind of locally in other areas, they may, like we've set up with our West Yorkshire setup, is ensuring that we've got some sort of shared care arrangements with those medications, because those medications are medications that GPs, whilst can prescribe, would only prescribe under shared care arrangements, in terms of making sure that the specialist has some sort of oversight with that. When they are in different areas of the country, that doesn't happen, and therefore expecting the GP to pick up on something which they may or may not know the quality of the assessment, but even if they accepted the quality of assessment, they don't, in terms of managing the treatment, there's no shared care arrangements with them. And that's why I think is the issue. As you said, as Kieran and you have said, it feels I wouldn't say pointless, but it feels a real waste of time for everyone there. But actually, and so that hopefully in terms of what the arrangements we're setting up locally is to ensure we've got quality assured private providers. And with doing that, part of the procurement is that they also have that support for shared care arrangements with our local GPs, so that we can prescribe them and can continue, so we don't have to then go back into a system there. So it's managing and dealing with that, even though we are a nation as such. The assessments are different, and also the arrangements in terms of prescribing won't happen across the nation. Does that make sense?
Thank you.
Thank you.
Okay.
It does.
Councillor Scopes.
Yeah, thank you, Chair. I just wanted to ask a little bit, I wrote back to you, James, I think, around inequalities on this, and I think it's worth just framing these in this public meeting as well. So I guess my real concern in this is around increased inequalities, and so the right to choose generally is not always opted by all communities across the area, and so I think there's an element of inequality there. And then I think there's also an element of you can also pay for assessments, and I'm particularly concerned about young people who are waiting a really long time in Leeds and across West Yorkshire for assessments, and so may not be getting the support they need in schools, whereas if your parents have the money to pay for an assessment, you might get that support much earlier, which might affect your education outcomes. And so I think this kind of, I guess my take is this kind of attitude, this kind of approach, which is saying, people just have to wait a long time, we can't just fix the problem, is really concerning for that vision in Leeds and across West Yorkshire around narrowing the inequality gap. And I think that's the thing. And then the other thing I just wanted to pick up on, comments around sort of those waiting the longest type comments. And I guess my concern again is there needs to be something around need as well as wait. And so if you've got a more profound need, or for example, if you're going into an important year, so I think this is a really important point around if you're in year 5 or 6 and you need an assessment in order to allow you to get the right school for secondary school, I think there's got to be something around that. And again, if you're in years 10 or 11 and you've got GCSEs coming up, and having an assessment may allow for some kind of dispensation and exam, again, it's not about the time that you've been waiting, it's about the importance of the moment you're in as a human being. And so I think the time is only one element. So I guess the question is around health inequalities, and the second round is around prioritising based on need and the time of someone's life that they're sat on the waiting list. Thank you.
James.
Yeah, no, thanks, Councillor Scopes. I think, again, important points. I think in terms of, and I think part of what we're trying to do here is to try and address some of those issues there. I think the kind of right to choose and those with kind of are who have more pointy elbows or have the ability in terms of with finances in terms of getting a diagnosis is currently a risk. And I think what we're trying to do is if we can make the approach easier and fairer, then we'll kind of minimise some of that need for people to go elsewhere there. I do think we are and we will be looking at kind of the inequalities and the impact this is having. I think working in our hubs, the development of hubs and working within our communities will hopefully also highlight that. I also think in terms of those who are, we've also part of the process of providers within West Yorkshire is about reviewing their waiting list to monitor kind of both the well-being and to escalate urgent cases, kind of who might need to be seen sooner there. I take your point about points in life in terms of especially education, as you've highlighted there. And I'd hope, as Keir mentioned in his summary there, those hubs will also involve education. And again, through those hubs, there not only can help support at that point, but also help in terms of kind of discussions about escalation at that point there. But it'd be vital, and it's part of our plan that education are very much part of those hubs there to support that there. So I'd hope that, yeah, I recognise what you're saying. I hope that our approach is looking to ensure that, one, we're minimising the risk of the inequalities, but it's something we've got to keep an eye on. It's something absolutely vital. We keep an eye on that there. And the second thing is around kind of the education and points of escalation. I think hopefully through those hubs, it will be about a needs-led approach. And it may be then, if we're seeing kind of at points in life that you've highlighted, that's where certain stakeholders will get involved more to help highlight and support. But that helps.
Thank you.
Can I just clarify this
Yep.
for my own, just getting it in my head? You're talking about the hubs down the line, not next year, possibly 27. And you're talking about getting education involved, etc. Why aren't education, etc., involved now?
So I think you're right. I think we do work closely with our education colleagues there. I think what we're trying, and so I'm not saying that doesn't happen at the moment. I think what we're trying to make sure is that we embed them in anything new that we're doing there, so that they are part and parcel of the response and the offer in terms of needs-led. We recognise that this is across lots of different sectors, and it's important that we're bringing in everything, and health is one element of that. And obviously an element in terms of assessment and treatment is very much sits with us as health, but a lot of solutions don't often sit with us, and therefore it's important that we are embedding them. But at the same time, and I would say that we are doing that now, probably not to the point that we really want to. And that's part of the reason of bringing the hubs together, to make it part of making sure we're working as a team rather than as separate sectors.
Yes, so I'm still not really got an answer on why you're not bringing forward that workers working as a team, why you need the hubs, why you can't be working as a team from now across different sectors, because the need is there now. And it's, yes, you're doing some things, but you're wanting to develop. And I don't really see the timelines correlating together. And that is one of my concerns. But I will bring in Councillor Griffiths.
Thank you. Probably got two questions. The first one has been alluded to before. It does seem to be entirely unsatisfactory that people can access services for diagnosis who aren't able to provide the appropriate treatments, whether directly or by using appropriate shared care arrangements. And it may be, I'm not sure if it's a Freudian slip, but somebody referred to people going to independent providers for a diagnosis, rather than saying they went to independent providers for an assessment. And I wonder, is there any way that can prevent? Is not quite the right way. Is there any way to tackle that problem, other than by trying to make the local service so good that people don't want to go to those providers? Because as has been pointed out, people who either have the money or have the money for transport, it's not, if you have to go a distance, it's not just about whether you have to pay for the assessment, it's whether you've actually got the wherewithal to get to wherever the external providers are. Is there any way of kind of dealing with that issue, other than by hoping that people won't want to do it because everything else is so much better? And then the second question or comment was around this question about the needs base. I absolutely appreciate you need to work on needs base, and whether it's needs in terms of temporality, when people have particular critical points in their life, or whether it's needs looking at the basis of severity. But the problem is that you can't assess the needs until you've seen the patient, and what's the process, and then but how can you know who to see first, because their needs are the great? What's the process for trying to actually identify those people who are the greatest need, to, if you like, move them, give them priority with the system? Because with the best will in the world, we're never going to be in a situation where everybody at whatever level of need can get a quick and a diagnosis which is satisfactory to them, or so a process which is satisfactory to them.
Yeah, no, thanks, Councillor Griffiths. I think in terms of your first point, in terms of can we do anything about going further afield, apart from trying to make our services better here, it's very difficult, because once people get once individual independent providers get an NHS contract, then that's the reason why they have got right to choose. And we have looked at kind of the opportunities to change that, but it's a national kind of diktat in terms of right to choose for the right reasons, but at the same time it causes the challenges. But it's very difficult to alter that.
Sorry, if I could very briefly come back
yeah.
on that. No, it's just that you mentioned about them having an NHS contract. I mean, what are the controls over an NHS contract? Is it possible to, why, in a sense, are NHS contracts being given to people who aren't prepared to provide treatment, for example?
And that's some of the questions we've asked ourselves. When it's done locally, they're allowed to, people can be offered treatment. Then it's about further assessments, and a lot of these are not face-to-face assessments; they're online, and therefore further assessments afterwards are challenging for people. And there, so from that point of view, there. In terms of the other point, in terms of the needs-based and the assessing people, so the hubs will be very much about. We will need to make sure that we've got processes in place that enable escalation to happen there, recognising not everyone's going to get the hubs are there to help with kind of looking at supporting people to where people need to get be assessed for a diagnosis. And what we need to make sure is that we've got a process that enables people to be escalated, enables people to wait, because just because they get referred into a hub does not mean that they're then suddenly immediately assessed. There will still be a wait for that assessment, but actually how do we make sure that we're assessing their needs so that their needs are met whilst they're waiting for that assessment? Ultimately, what we want to make sure is that we're getting the right people being assessed quickly, where it's imperative that we are, rather than a situation where we have huge amount of people with demand to be assessed. Some who want an assessment for their own knowledge. Some will have a major impact for them in terms of work and other issues there, and some particularly around education as well that's been highlighted already there. And what we want to make sure is that we're getting the right people to being assessed, and being assessed as quick as possible, and both whether it's a kind of clinical issue in terms of urgent cases, whether it's kind of situation that they're in, that we need to make sure that there are processes that enable them to happen, recognising that not everyone is going to need a full assessment, and some just need their needs to be assessed, and then kind of offered some of their needs, and that may be out with that hub, but within our voluntary sector, within education, within our other elements of health and kind of mental health and things like that. So so I think it's making sure, yes, we have got a process, but the hubs are there to try and help also make sure that we can almost triage some people where we feel we've got to get them seen sooner than maybe some others, recognising it's important for everyone, but also at the same time it's recognising we meet their needs as well.
Okay. Councillor Hutchinson.
I've got two questions. One's a very specific one. You mentioned one of the things that keeps being raised with us is the transition between children and young people services and adult services that many patients and their families have likened to falling off the edge of a cliff.
Yeah. Is
there anything in your plans for services that will address that? Because I've not seen anything in the report.
The simple answer is yes. It's very much a focus. It's one of the areas that we've that was highlighted. It was Keir mentioned about some engagement sessions that we did last year, and that came up as one of the issues that was kind of picked up on there. So you're absolutely right, and I can understand how you've heard about you would be getting correspondence about that as well there. So we are looking to make sure that people, and part of that will be about some of that threshold work that I've talked about there, to ensure that we're not having someone who's been diagnosed in their childhood and then coming to kind of adulthood and then having to go through a further assessment as a result of that. So that part of this is about equity in both in terms of age threshold as well, to ensure that we're not suddenly changing the diagnosis because of age there, or the assessment of diagnosis, should I say, sorry.
But it's also the support services, not just the matter of having a label, a diagnosis.
Yeah.
That seems to be missing and needs attention. My other question was, you pointed to the limitations of the provider selection regime. We know that the ICB has a finite budget, and more money spent in one area means less money available to be spent in another area, and it's important that the ICB gets the best bang for its buck across the board. The provider selection regime seems to be fairly toothless from what you've described. So the ability for the ICB to actually control the flow of work seems to be quite limited. In this respect, are there other areas of clinical work across the ICB in which this is also causing concerns? The ability to actually, the risk of funding being diverted down one channel and not being available to be used for something that may be a higher priority.
Yeah, so I think we do look at it as a whole system. As you say, it's kind of making sure that we're spending the right money in the right places to ensure we get the right treatments and managements and assessments there, and across both across our physical, mental health, LD, autism services. It's about it is about elements of prioritisation. There are times when things may be limited. We've seen that. We've seen that across the country. We've seen that across our ICB as well, in terms of limitation there as a result, because we've only got a finite amount of the West Yorkshire pound to spend there. So I think it is taken in within the realms of wider context as well. I think there's no doubt that neurodiversity is high up on the list in terms of the challenges that people are seeing there. It's very much in the thoughts and discussions there, along with other services and physical services as well. So it is within the planning cycle and understanding that, and it will be about decision making, and sometimes that will be some hard decision making as well. But it is part and parcel of it.
But are there any specific areas of service, not just within mental health, where these pressures are coming down the line?
I think it would be fair to say yes, there are. I think we've had I think recently we've had discussions around ophthalmology and some of the services there. It's fair to say, and I understand your background, but that would be another area I would suggest that we've seeing those limits, seeing the kind of potential growth demand and what that means on the West Yorkshire pound, and weighing that up across the system. But so that would be one example, but we need to probably look at others.
Weight loss services.
Yeah, I think that's other things. So I think there are other services that we will be looking at. As I said, all of them will have to consider it within the realms of planning. I don't think anything's out of reach in one sense. It comes down to our priority and looking at what the demand is.
But it does sound as if we're actually quite lacking in the tools to be able to to actually influence those flows.
I think we're trying to use what we can in a fair way, and do that in a transparent way as well, so the public are aware of of how we're spending and what we're spending things on. I think sometimes there will be a need to have wider discussions on that, so that when we make those decisions, and when we have to make some of those decisions, people understand the reasons behind that, and the context that you're putting this in as well.
Thank you.
That's right. Thank you.
Thank you. And I would say also visibility of decision making, and changing services, and the need for scrutiny on changing of services. But Councillor Rhodes.
Thank you, Chair. Yes, it's still good morning. I'm just looking at the clock. Good morning, both of you. Do I understand, James? Did I see, or am I looking at a different paper? Are you a GP?
Yes.
That's good. Right man in the right place. Okay. Right. I fully support the comments that have been made already in terms of my colleague's contribution here today. And to be honest, I don't see any equality in it at all, equality of opportunity. I think that's been mentioned. The combination of people working together is vital. But I've looked at this report, and my first question is this, and I'll make them short so you can have a short answer because I'm conscious of time. You're a member of the SOGA team, yes? Both of you here today? SOGA?
Yeah, yeah.
Are you a member? Okay.
The SOAG, yeah, yeah.
Yeah. Systems Operation and Assurance Group.
Yep.
Okay. Councillor Spage and myself go back a long way in terms of the establishment of ICB boards, because we were in shadow for about 5 years. So acronyms are everyday words to us, but I just wanted to make sure we got it right. I have to say that I'm getting a feeling that this is more of a research project than it is an outcomes-based decision-making process. When I read the report, I see that between 22 and 24, extensive engagements took place with various groups of people. And out of that, you got long waiting lists for diagnosis, inconsistent post-diagnostic support, and fragmented and confusing care pathways. And then you had agreements out of the summit of the action that would have been taken and needed. And I have to say, I'm going to go back on some of the areas here today, if I may, first of all, Chair. First of all, when you scoped this project with the information that you have in every authority, every education authority, and every social care authority who are your partners, did you start from their base or did you start from your own information? How did you scope this project of this report?
Yeah, do you want to come in on that, or?
Yeah, thanks, Councillor. So I think coming back to the summits that you referenced, one of the real reasons for undertaking those summits was so that we get all the different partners in the room to understand what is people's lived experience, what's the view of our clinical professionals, what's the view of local authorities, what's the view of education.
Here can I interject, dear? Here can I interject? I'm conscious of time. I keep looking at my clock. This is such an important report. What I want to make sure is if I ask the question, I get the answer, not what's in the report. So for 22 and 24, you had a list of actions outcomes from those groups that you met, quite rightly, and well done. So what has happened between 22 and 24 before we've actually seen this report here today? Has any of those intentions of need started at all?
Okay, so coming back to the point I was making, which was essentially the summits that set out the direction of travel. We've then done the work to agree what does that look like in West Yorkshire. So the SOAG that you referenced, that group was the group that went, okay, we've heard everything from the summit. What does that need to look like? And that's what came out with the outputs of we need a unified commissioning policy. We need to develop the community neurodevelopmental hub. So we've gone through the work to go, what does that look like in West Yorkshire? And now we're at the point of going, that's the plan.
You're going into my next question now. I'm just wanting the brief answers, if I may, because I know the Chair and others want to have something to say about it as well. So between 22 and 24, you had your information. So then you went into the development and agreement of how important hubs are out there in the community, okay? How many of those have been developed and where?
None yet.
So we haven't developed any yet.
So you haven't developed any yet, James. Okay, that's very interesting. And what's the timescale for that, if I may ask both of you?
So we're wanting to get the hubs up by the end of 27 financial year.
Okay.
26, 27.
Okay. Well, that's what I've written down, actually, James. So thank you for reminding me. I had put 27 down, and my God, I have to say, and please forgive me, God, for bringing you into it. I have to say that anything that takes so long to implement on information you've got of need turns out to be more a research project than an action plan. And I'll go on from there. Secondly, when I looked at the situation again of this report, obviously support the hubs, obviously support connectivity with all the agencies. And one thing I have to say about it is that you have agreed on key issues. First question, waiting lists. How many people across West Yorkshire are on waiting lists for an assessment? By the silence, I'll take that by the silence, I'll take that you agree there's waiting lists, but can you tell me the numbers, please?
Yeah, so can I just come on that one? So it changed a lot, and we don't have back to my point about regular data flow. It's not something that we have at a touch of a button, but what we do have in the report that went to SOAG is the position at that point. So I might need to write to the committee if that's all right to check the numbers, but we do have the number of people who were on the waiting list when we had the SOAG report. What we don't have is on a monthly basis what that number looks like because we don't have the data.
Okay, can I suggest, Keir, that in that case, when you write down key issues, it would be important in advance of the report to get that detail for us, because it would be very helpful. Can I then suggest that following today's meeting, you get those data as much as up to press that you can and submit it to the chair and our officers, who will then forward it on to us. And it says in that report in key issues as well, the trust is priority and support for individuals with complex needs only. Now, we as elected members out in the community, knowing our community and knowing the issues that are out there in terms of assessment and need and support, complex needs, that covers a huge area in terms of the individuals concerned. I think as well as the information coming out, it would be useful to identify the criteria you put down to complex needs. You don't have to answer that one. I think enough has been said about the right to choose, which everybody has. But the question was asked of you by another member here, because you said you have contracted providers out there to ease the burden on people who are waiting assessment. I applaud that, because that's been having to be done for years and years, too many years. And I know a family years ago who had very little income, and paid £30 to go to Sheffield to try and get an assessment. I thought those days had diminished in somewhat, but it seems to be money will be the key target in that. And then obviously, as you said, no medication. Quite rightly, James, I believe that point is vital out there for people to understand that. And then you have variations across localities in access and equality and waiting times. And we do know that. We do. Really appreciate it. But the other part about the report is we've got a graph here, NHS England numbers 2019 to 23, which has showed an upward trend. Now, I'm sure as a GP, James, you may have seen a little snippet that came out maybe 2 weeks, 3 weeks ago. And it was from a GP from a practice and his concerns about the increase in numbers and waiting and assessment. And he actually had a thought that that was maybe, and only a maybe, allocated to a misdiagnosis at the beginning, rather than looking at more in depth in terms of the position of the child or adult who can suffer with this. Is that something that as GPs you've been able to?
Sorry, so can you hear me?
Yeah, I think
Oh, no.
she's just having connection problems. But if
But-
you,
I'm
she's
back in,
back now.
James.
Yeah,
I'm
yeah.
back in.
Okay.
Are you, I mean, I know as GPs you get together.
So I think the
You want
issue
to
with it,
answer that, James? Yeah.
I think I may be wrong in terms of are we in terms of the diagnosis, are we getting it right? And I think part of I suspect at times we're not, and therefore it's important. I think part of the reasons we want to kind of standardise the kind of thresholds and the assessment process is to enable that we are getting it right where we need to. Also, part of the hubs also might be that as people are waiting, they get their needs assessed. Maybe not get assessment for diagnosis at that point, but they get their needs assessed. That actually they then get their needs met, and then actually don't feel that they need to go on for a further assessment. Whereas in the past, that may have been assessed and possibly may be misdiagnosed at that time. I'm not sure, but I think it is something that I'm aware of, and I'd hope that through the hubs, as we go a needs-based approach, that we will have a better way of we will enable people to get their needs met. That they may feel that they no longer need to be assessed. And therefore we won't get a risk of misdiagnosing. The other aspect I think also is that sometimes mental health issues have been confused with some of the diagnosis, and again, it's important that we are if people are seen that they're having their needs met for their mental health, that they may not feel that they need to be assessed for go through the assessment. That can work the other way around as well. I appreciate that.
Okay. Councillor Rhodes, are you back with us? Okay, all right. Can I
Thank
ask?
you, Councillor.
Can I ask on this matter about referrals and assessments? So
Hello, I'm
if
back. I'm back.
all
I'm
right,
very sorry.
it's
I just
okay.
dropped out completely. I do apologise.
It's okay.
I'm sorry, James. Did you manage to catch those questions? If it's I know you've probably got to leave, but you can make note of those and get us an answer back if that suits.
Yeah. Yes. Yeah. We'll let you have the answer while you dropped out, Councillor Rhodes. We'll let
Thank
you
you.
have the answer. Okay. All right.
Oh, you're there. You've gone down to the
Yeah,
bottom, James.
yeah. Okay. Can I just ask about referrals? Because if you're doing this on looking at the needs and the critical needs, complex needs, then that depends on the referral. Assessment of that depends on the referral.
Yeah.
So how are you ensuring that the referrals are consistent across West Yorkshire as well? Because if they're not, if one person is better at writing a referral than another, then they may get seen before the other, but the actual need may be the other way around.
Yep, I think that's always a challenge with any referral pathway. I think, but at the same time, I think with this, I think we have got nice guidance. I think in terms of helps us with that. I accept that some of that nice guidance is being challenged or is being questioned at the moment, but I think what we would be expecting is that our referrers follow the nice guidance, which is generally what they do there. I think it would then be the plan would then be as they go through the initial phase of the referrals that, as I said, it would be looking at a needs-based approach there. And I think if anything was being highlighted in terms of it's not coming across the way the referral is, then we'd be kind of looking at kind of how we manage that, whether it's escalation or de-escalation, depending on the approach.
All right, and can you talk to me about demand as well then? Because you've got this activity plan that says providers can have the same level as last year plus 10%. But your demand isn't necessarily at the same level plus 10%, is it? It is higher. And how are you going to ensure that because of this activity plan in place, your waits in some areas don't actually elongate, and you're just going round in a complete circle all the time?
I don't know if Keir wants to come in, but I would say it is a challenge I have to be honest. I think we're doing that as in order to kind of recognise the pressures that are on us as a system, and going back to Councillor Hutchinson's discussion about kind of the pressures on the financial pound in West Yorkshire there. But at the same time, it's how we meet the needs of our population as well there. So I think it's something we will be continually monitoring. But there is a real risk there. Keir, is there anything else you want to bring in on that?
Yeah, no, I completely agree. There is that risk. I think the most fundamental part is about making sure that there is equalisation of the weights, so that people may wait longer in some areas of West Yorkshire than they have done historically, but they won't be the extremes of weights we've had, or the kind of the variation in weights. And actually, coming back to the logic for the neurodiversity hubs is that will be the critical bit over time, that if that works and we're getting people the right support early enough, it might mitigate some of the demand on the need for an assessment or a formal assessment. But in the meantime, that it's about trying to make sure that we are equalising the weights across West Yorkshire with the processes we've got, recognising exactly your point, Councillor Smaith, that even a 10% uplift in the kind of the access that we can provide is not going to necessarily mitigate the doubling of demand that's coming through. But taken in totality, it might lead to more of an impact on supporting people and with what they want, rather than relying on the assessment.
Okay. Yes, and it's how you manage that demand. And I think Councillor Rudd's query about letting us know the numbers on the waiting lists, I think that is important. But I think ongoing, I think we would want to see how this is being delivered and how this is affecting everybody across West Yorkshire. I really do. I also wanted to ask as well, because girls can mask the symptoms better than boys, I think, if I've got that right, for autism. And so they may come in later to the process than the boys might. Has that been taken into account as well, that symptoms, or not symptoms, characteristics can be masked?
I think that would be part of ensuring, in terms of our assessments, are fair, and that we take into consideration the various different aspects of that. So I think that will be part of the work to be done.
Okay. And how does the national review that's been announced, that will include these services, how are you expecting that to roll out in line with what you're currently undertaking?
Yeah, so I think we'll wait the national review, but I think from all the discussions we've had, kind of regionally and with the national team, I think the direction of travel we are taking is very much one that they're seeing nationally. So I'm not expecting a sudden turnaround in a completely different direction. However, obviously we need to wait for that review. Keir, are you happy with that, Keir? Yeah.
Yeah, absolutely.
Councillor Rhodes?
Sorry, I'm back with the last question, and I do apologise, James and Keir. It's just falling out. The system is dropping away here this morning. Can I just come back to the future in terms of places? And I'm sure you know that there's going to be changes as we move along. The proposition of change in places out there, and when we are looking at the designation of hubs, has that designation of hubs across the patch in West Yorkshire formed any part of where the access of need is going to be, available? Because as we go through change for the future, and particularly with a 10-year plan, as we go through change, the neighbourhood level is important. We speak about hubs. Closer to people, is actually preventative as well. So has there been any correlation about, as of now, how you've looked at this in the present context, or any change for the future, how those hubs would actually be within a future neighbourhood position of health?
Yeah, do you want to come in? And then...
Yeah, thank you. So I think kind of the starting point at the minute is that we have our 5 existing places as they stand at the minute. in developing those business cases for the hubs is to try and understand, well, what is that footprint? So, for example, is it a hub that you need one in Leeds, one in Bradford, one in Kirklees, one in Calderdale, one in Wakefield, or is there something different that we do at a lower or higher level? But to be honest, we need to do that work to understand what's going to fit best, particularly because of the reliance on the other partners as well. So that bit about if we're bringing in education, bringing in local authority, bringing in BCSE, it needs to work. So we don't have the answer to exactly what they'll look like, but it's a trying to develop that as part of the business case.
This
Councillor Rhodes. Oh, sorry, go on, yeah. Oh, I think she's frozen. I think she's got technical difficulties this morning. Right, okay. Well, we'll wait to see if she's able to come back into us. Are there any more questions on this item then?
shape or form to the
there
board
she is.
itself.
Sorry, Councillor Rhodes, your system froze again, so we just caught the last few words of your question. No, I think. Are you there, Councillor Rhodes? Your system froze again, so we just, yeah, we only caught the last few words of that question, I'm afraid. Okay, all right. Can I just ask then that we talked about partnerships, and I think that building on partnerships is really important, and it shouldn't wait until the hubs are in place. That work is actually going on. That the ICB do not internalize this. That they talk to people across the board as much as possible and bring in all the different agencies to this work. I mean, there is something really, really simple. I looked up your website. And yes, it's got frequently asked questions on there, and they're all health related. And then another page has got links to national charities. Fine. But I didn't see any links to councils' pages, the different pages, internet resources for the different councils, so that people could look to see, all right, what support is in my area then. And that to me is something really, really simple and can be done straight away. And but it is symptomatic of the fact that this is of the need for more partnership working. Okay, all right. Councillor Rhodes asked for the numbers on the waiting lists and also the criteria on the complex needs. We talked about clinical thresholds, and you're working on those to March, and I think we would like an update on that. Your hubs work is a long-term process. We talked about inequalities and ensuring that this work does not exacerbate inequalities in this process. And we talked about also the reviewing of your lists and urgent cases and the demand, managing the demand, and that doesn't become more in some places than it is now, and about needs-based and a whole system approach. And can I also say as well that maybe we would appreciate having conversations a lot sooner than this. About changes. We would really appreciate that, and in fact, that is what should happen. Okay. So if you can speak to officers, etc., about how we can move forward with the committee receiving updates on this work, please, because I do feel that we would all want it. Have I got that right? That we would all want to know how this is progressing, and in fact, ensure that those waiting times do not become exacerbated because of this activity plan that's been put in place. Yes? Yeah. Okay. All right. Okay. Well, thank you for your time on that one. We'll move on then to winter preparedness. And Deborah, is this yourself?
It is, yes, Councillor Smage, it is me.
Right, okay.
Good morning, everybody. I've got Rob Goodyear with me. I think he's on my next page, but I know he's there. We're just, I've lost him, but I found him. That's jolly good. we're going to just I've got a few slides that just give you a little bit of background around winter, and then just a little bit of update on our performance. They're very much the slides will take us through the paper, and then I'm going to hand over to Rob that's going to give us an update on the vaccination programme. So if there's no questions, I will move on.
That's fine.
Well, if I can find my presentation, it's always the way, isn't it? Okay, let me just move up to the first slide. Beginning. Can I just check everybody can see that? Okay. Okay, so I just thought, this isn't included in the paper, but I thought a little bit of background would be really helpful. And this is just a little bit about the context of the National Urgent and Emergency Care / Winter Plan for 25-26. So the focus of NHS England and obviously the wider Department of Health these days was starting to look at the strong link with any plans that we did have around our development of our UEC strategy and the development of our neighbourhood teams going forward. So a bit of a focus on that long-term 10-year plan. The investment in our infrastructure, again, focusing on that 10-year plan, digital tools and estates. I think most importantly here, prioritising patient dignity and safety and ensuring that we have got the right number of ambulances on the road, which I'm sure you're all aware is a constant challenge for the health system at this moment in time. Also focusing on discharge, ensuring we've got enough capacity, and again, focusing on moving services out into the community. So this is really starting to build the frame, but obviously it isn't something that we can do extremely quickly, but there is things in here that we've focused on as we've been developing that plan. I think this is an important slide. This is about the West Yorkshire winter planning principles, and we've had these in place for about 4 or 5 years now, and we review them every year, but they don't seem to change very much, because we've got some tried and tested processes that enable us to build some really robust plans. Important for us to recognise that system resilience isn't just about winter, and I'm sure you're all aware we do have challenges throughout the year, but we do see some real enhanced challenges during the winter between October and March. It's really important that we focus on our staff during this time, because we know that obviously our staff get just as sick as our patients. Health inequalities is integral to all of our plans in winter and for obviously those 365 days of the year. And we are really strong on our clinical engagement and our leadership, and that's across the ICB, but obviously within all of our providers, it's our clinicians that are understanding and developing the needs of their individual plans. We look at all our data, including our public health data, and we have weekly updates from our public health consultants in NHS England about the rise in any infectious diseases. And there's a focus on prevention, a real focus on the vaccination, and been an additional focus this year on the infection prevention control, which was a real challenge for us in 24-25. As I said in the previous slide, we start to consider the impact on our wider transformation schemes and how winter can have an impact, but how we can expedite things for winter as well. And we always, through our principles, start to do a review on winter. In a couple of years past, we've done it in March, even before winter has stopped, but we usually do it around the end of May, June. We start to look at all the data and everything that happened in the previous winter to inform how we want to approach this winter. We have good command and control arrangements in place, and we always go through a robust testing of our plans. And our communication plans are obviously really key in planning for winter as well. The next slide just gives you a little bit of an idea of the things that we consider, and this is our whole system approach across all of our partners about how we're doing the resilience of our planning, our winter planning requirements, and what we mustn't forget is the delivery of our core services, because we have to deliver those throughout winter. We can't just concentrate on delivering our emergency departments, which seem to face the biggest challenges. And as you can see, right in the middle of that is our quality, safety, and the experience of our patients, and focusing on those inequalities as well. So our winter plans were signed off in September, and since then we have got the oversight and control in place. So our winter plans are developed at place. So each of our 5 places work together to develop those plans, and they will manage their systems and their winter challenges and escalations at a place based as well. We have a weekly winter steering group, and that's all of our places and our programs, so we can understand some of the things that we need to put in place, and then following once the plans have been signed off, we do that on a monthly basis, just so that we can all keep an idea and do some learning from good practice and things that are happening. We took part in a national winter exercise on the 3rd of September across the region, and we had extremely good attendances, and there were some really good actions that came out of that for each of our places to go back, and there was some further testing in places as well. This year we were required to fill out a board assurance statement, and this was signed off by our CEO and chair on the 23rd of September and approved by NHS England. On the 1st of October, the new regional reporting regime was introduced, and that includes winter trigger reports across 4 areas, which I'll cover in a future slide. And we've received some extremely good feedback from NHS England about the level of information that is in our winter trigger reports and the ability of our system to recover well after its challenges, and with some really, really good plans in place to manage those challenges. We've got some really developed ongoing communication strategies, working with partners to ensure targeted messages. We've got robust escalation processes in place with winter SROs, as I said, place meetings, and the System Control Centre continues to operate, and they're supported by robust on-call processes out of hours. And we attend a twice-weekly regional meeting to share learning and actions across the region with the other ICBs and NHS England. Our board assurance statement, just a very quick slide on this. The purpose of this was to ensure that the ICB board had oversight and all the national key recommendations had been met. And as I said previously, this was signed off by the accountable officer and the chair on the 23rd of September. It covered governance about our partnership development, our stress testing and our leadership, the plan content, risks and our daily management processes, vaccination and admission avoidance under prevention, and winter demand discharge and our ability to maintain elective care, and as I've said before, our ICB winter SROs and our robust on-call process and escalation processes. As with anything, there are a level of risks, and we have identified 5 top risks for this winter. Obviously, patient safety with the increased surges in demand and the high acuity of our patients, workforce challenges with staff sickness and increased demand on health services placing strain on our staff, the service of resilience of our services, our current financial constraints and our ability to provide any additional winter initiatives, though I'm pleased to say that we have continued with our virtual wards and our ARI hubs in each of our 5 places. And obviously the organisational change that we are going through was originally a risk in retaining the System Control Centre, but we have found a solution with that and are working very closely with one of our partners to support us in maintaining that. Just a little bit about the winter triggers escalation. This is a regional thing from the North East and Yorkshire, and there are 4 triggers. And when any of our providers, our acute providers, reach these, they have to submit the reasons why and plans for the future. And that is our ambulance delays, ambulance handovers over 1 hour, long waits in our emergency departments, and that's extensive waits, which means there is ED congestion and the system is looking to go into severe challenge. Just a little bit about our performance. This is our performance up until October against our operational plan that we put in at the beginning of the year. And as you can see, for our A&E department, we are actually above our plan. We plan to be at 73.9 in October, and we're actually achieving 76.7. for 12 hours in department, the national target is for us to have less than 10% of people waiting more than 12 hours. Our plan was 7.6, and we're actually in October declaring a 7.1. And our category, our 4-hour target for children and young people, there is not a national target, but it's an area of focus. And in October, we achieved 89.5. And our Cat 2 response time, our plan was 32.23, which was below target, and we actually achieved a 28.2. So we are tracking above plan at this time, but that was in October. Obviously, we know we started to have some pressures towards the end of November and at the beginning of December, so we'll be able to see what that's looking like over the next month or so. This just gives you a little bit more detail. It was in the pack about each of our trusts and their 4-hour performance. And as you can see, we have a couple that are tracking below, which is Airedale and Mid Yorkshire, but both Bradford and CHFT are above target, and Leeds is just hanging in there on target. And this is our 12 hours. So pleased to say, as I read out the data, all of our trusts are below the 10% target for people waiting in emergency departments for longer than 12 hours. So that's the end of my show. I will stop sharing and I will hand over to Rob, who's going to take us through the vaccination programme. Thank you. Thanks, Rob.
Thank you, Debs. Good morning, everyone. My name's Rob Goodyear. I'm an Associate Director working in our Clinical and Professional Directorate within the ICB. So you'll have seen from the paper that flu vaccination alone, there were 8,000 deaths last year across England, and we estimate that the flu vaccination prevented 100,000 people being hospitalised last year. As part of the winter planning that Debs has referenced there, since the publication of the Urgent and Emergency Care Plan in June, we've been working closely with planning colleagues, our places and our providers, including our local authorities, as a West Yorkshire system. The flu campaign started in 1st September and the COVID campaign started the 1st of October, and they will finish February and January respectively. In terms of achievement in targets, we've exceeded all of our COVID vaccination targets for care homes, those over 75, and those who are immunosuppressed. For flu, we've achieved the target that was specifically set within the urgent and emergency care guidance in June about increasing the vaccination of frontline healthcare workers. That was a specific ask to increase by 5%, and we've achieved about 44% of frontline workers compared to 37% last year with flu. We continue to work in towards the other cohorts, and we're close to achieving those targets for flu also. To achieve this, as Deb's alluded to there, we provided leadership at a West Yorkshire level, escalating risks to a specific vaccination and immunisation strategic steering group led by our chief pharmacist, which is part of the governance for the ICB's approach to health protection. And we've implemented a winter operational delivery group to provide that leadership, work collaboratively, share good practice and provide updates. We've shared consistent messages with letters from James as our West Yorkshire Medical Director, Directors of Public Health across our system, including ones that target our care homes and our frontline staff. This has all been built on our do once approach in communication terms, and together we can campaign that we have built on from last year. We've used all of these assets for remote vaccinations at staff briefings, at our Urgent Emergency Care Board, our Health Protection Oversight Board, and our Place Health Protection Boards. So it's a great opportunity to come today as well to give this update. And we've taken the opportunity to frame flu and COVID vaccinations as part of West Yorkshire's life course approach. There are other preventable infections during winter, such as RSV, as well as all year round infections, such as measles and MMR. And finally, I'd just like to put into context the press headlines that you may have seen over the last week or so about the highest ever flu rates. So our public health colleagues in the UK Health Security Agency predict infections ahead of winter and are clear that this is the week we would usually see flu pressures within the system, that positivity is rising. We are running only a week ahead of forecasts and the normal flu seasons that presented in 22, 23 and 24, 25. There's nothing in the data to suggest that this will be worse in terms of clinical pressures. ED attendances for acute respiratory infections are similar to those of last year. GP consultations have risen steeply, but this is similar to 22, 23, and we're perhaps 1 or 2 weeks ahead of last year's flu season. Hospital admissions for flu are similar to last year, although we are 1 to 2 weeks ahead. And in North East Yorkshire, bed occupation for flu is similar to that year, so similar to last year. So I thought it was really useful to put those headlines that you may have read in the press in some context with what was predicted ahead of the flu, the winter season. So I'll stop there and happy for us to take any questions on the subject. Thank you.
Okay, thank you. I'll open it up for questions. Any questions? Councillor Griffiths.
Sorry, just quickly on the graph with the flu vaccinations, just a technical thing. It showed, sorry, the winter viral illnesses graph. Your left-hand scale is percentages. What are they a percentage of? I just have to look at that. Can I take the next one while I just check that one out, Councillor Griffith? Thank you. No worries.
Okay, Councillor Hutchinson.
Yeah. For many, many years, the main pressure on the hospital services has come in the days and weeks after the holiday period. And a lot of that seems to be because the wheels fall off the continuing care and surveillance of patients whose care is being managed in the community and primary care. What measures are being taken in the winter plan to maintain the continuity of service for community care and primary care over the festive season to try and reduce that bulge of demand on hospital services that comes after that, immediately after that period?
Deborah, is that yourself?
Yeah, I can take that. I don't know if James wants to come in being a GP, but I can answer that one. I think we do ask for extra plans so we obviously have the base plans, and then as we move into the festive period, we will ask for extra plans around what is happening around pharmacies, around general practice, additional hours for general practice. I think we have obviously 24-hour services with our GP out of hours services, and they run right the way across the festive period, and we know that our urgent treatment centres continue to be open as well. I think there is something about that prevention and that risk management of the most vulnerable patients within primary care. So obviously there's always a discussion around making sure that general practice are looking after those set of patients. So obviously within our plans, we will get additional plans to find out what time services and everything are over the festive period. But it's very hard, isn't it? And I think it's not necessarily what happens at Christmas. We are always going to get additional demand. We usually always, if you look at all of the data, will, because we've got people mingling together, families getting together, and obviously that always has a higher percentage of people getting infected with flu, COVID, or whatever is out there. But we have really, really robust plans in place as part of those winter plans, and we obviously will get additional plans. I don't know if there's anything else, James, you want to add from a primary care perspective.
I think you've covered it really well, Deborah. I'm aware of time as well.
Okay, thanks. Rob, did you have that answer for Councillor Griffiths?
Thank you. It is the percentage of patients who will have any of those 4 infections, so influenza, rhinovirus, RSV, and COVID. So we can see there, that's a graph that shows public health, UK health security agencies prediction of when we will see peaks in each of those infections? So, as for example, in January, 28% of the population at that time will actually have flu. That's the prediction from our UXA colleagues, yes. Thank you.
Okay, thank you. Are there any more questions on this item? Can I just ask about, you talked about triggers, etc. One of the things we see in the press is about people being treated in corridors. So is that part of the trigger system? Is that what how is that taken account of in these winter pressures?
So it's not one of the triggers, but it is something that we do report on and to NHS England on a daily basis. So we will know if there are people on corridors in the temporary escalation places.
Okay. All right.
So we do report on it, and there is data available for it. The difficulty is with some of it, it depends on how because it's not a national thing that's reported on. We do know that there is variation across all of the trusts in what they're actually reporting.
Right. Okay.
So it's quite a tricky one until they kind of bring it in as a set criteria. Oh, losing my voice. As a set criteria,
yeah.
It's difficult. We get a general idea, but it's not something that we've got robust data on because they're all collecting the data in slightly different ways, because they've all got slightly different services within their A&E departments, depending on the size of the trust across Yorkshire, but also nationally as well.
Okay. All right. Thank you. Are there any more points on this then? No. Thank you very much anyway for that really well put together presentation. Thank you. Can I thank all members of the committee for attending this morning. Thank you very much for your time, and we will work on the next meeting's agenda. Thank you.
Thank you.